Okay. So is it visible now? It's in the presentation mode. Can somebody confirm?
Yes, sir, it's possible.
So it is in presentation mode, right? Okay. So today we are just going to talk about the tele-mental health services. So tele-mental health services, nothing but providing the mental health services support using the telecommunication technology, which involves, uh, a video call or a text or mails or phone, all those things involved in this mental health services. The objectives of providing the telemental health services is increase the accessibility, enhance the convenience because anybody can anywhere join and discuss their needs with the mental health professionals, right? So that is the primary, asset of telemental health services, and reduce the stigma. As we know that like lot of mental health awareness movement is going on, still some of the stigmas existed in the society where people might be feeling difficult to reach out to the in-person mental health services. So for them, it is like hands-on, availability resource that where telemental health services can be provided, and it improves the continuity, and it is also a cost efficiency, right? So these are the basic understanding about the telemental health services. Basically, there are two guidelines per se, which I primarily focused on today's presentation. One is APA, tele guidelines, tele psychotherapy guidelines or practice. The second one is where in India, after especially the COVID, NIMANS had adapted the tele mental health service manual. So basically, I'm just trying to focus on these two different guidelines. So uh, whenever you feel or you wanted to ask some question, please keep a note in it. So once we done with the presentation, probably when we have a time for discussion, we will discuss those and then clarify. So before going into the detail of tele-mental health service, I just wanted to uh, give a gist of like how this tele-mental health services has been emerged in worldwide, and then the India when it had come to India, and then how uh, when the people started adapting to the tele-mental health services. So in 19th century, United Kingdom is the first place where the telemental health services has been initiated. So initially, this is known as a Samarthans. So they named it as a Samarthans. Basically, it is a volunteer services where they not use the term counseling or therapy per se. It is more like emotional support services which they were named after a successful run of this Samrita. Many countries started adapting this telemental health services, in which India also adapted. They named it Be Friends Worldwide, volunteer service for the mental health issues. So it is basically again, it is a voluntary system based, and then it is primarily focusing or using the term emotional support rather than the counseling or therapy support per se, right? So this is how it started, and then there are many changes after that. So in India, 1976, Sanjeevani Society for Mental Health in Delhi. They were, started the uh, mental health support. Initially, it was a community and then in-person based services. Later, in the year of 2015, it has changed into the tele mode. Okay. Similarly, 1986 NEHA, mental health crisis intervention services based on Chennai, it has also started, and then similarly they also adapted to the mental health tele-mental health services in the year of 2015. Okay, so apart from this, there are a lot of government helplines which probably we'll be discussing, end of this presentation. What are the different services which has been provided by the government organizations and how they are effectively working in the community, right? So yeah, so basically this is about the tele mental health movement in India, like how they've started, and then as we know that after the COVID, the a change of mental health services has been taken very different place. Before that, there are studies shows that before it was there, tele mental health services is there, but around 10% of people only using that modality. Left 90 to 95% of people who was reaching out to in-person services, they would after the COVID, it has been completely shifted. So uh, where there is no mobility for the people to reach out, tele counseling and tele mental health services has been initiated. So now you can see that around 60 to 70 percentage of people still rely on the tele mental health services, and then around 40 to 50 percentage are still going for the in-person treatment. So this is also the current database which is showing to us. Okay, fine. Now let us understand what is the basic difference between the in-person versus the telemental health services, right? We will discuss about the four differences. So in terms of the ethical and legal part, both are remain same, right? So we know that like what kind of ethical and legal responsibility is there for the clinician, which we need to be, take care in when we are doing a mental health service with the people, those who are in need. So that is remain same. More or less, like some of the component need to be a little bit more, focused, but more or less it's similar. Having said that, there are limitation and advantages in both services. In person also there are some limitations and advantages. Similarly, when it comes to tele-mental health also, there are certain limitation and then advantages, as we discuss that in the later part. So as we know that the legal and then ethical part is very very crucial, I would be focusing a little more on that aspect because uh, it is so shows distinction difference between the tele mental health services versus the in-person mental health services. So as a professional, as a mental health professional, we should be well aware with our what are the relevant policies and laws that is available when we involve in this kind of treatment, and then when we are offering mental health services to the need people, we have to be very very careful, and then we have to keep all this rules and policies in our mind, right? Okay. So who can provide the tele mental health services? So the qualified and trained mental health professionals who have postgraduate in psychology can intervene people those who have psychological problems, and MPhil in clinical psychology when they completed the MPhil in clinical psychology, they can, deal psychological disorder. I understand, like, I hope you know the difference between the psychological problem versus psychological disorders. So I don't want to, go more in detail of this. If anybody wants to ask a question in this aspect, you can ask. We can just have a brief discussion. If not, we can proceed further. So I hope everybody knows the difference between the, psychological problem versus psychological disorders. Fine. Now, who can receive this tele-mental health services, right? So individual who's experiencing distress and mental health challenges and familiarity with the technology and its application, because unless until they know how to use this tele means, they'll not be able to access the services, isn't it? So that is the reason that they should have minimum, uh, knowledge about like how to use this technical applications and the technical means. So possessing adequate cognitive ability also one of the main criteria, right? If at all they have some compromised intellectual or cognitive uh, ability, it will be challenging for the clinician to make them engage in the conversation, and then it will not end up any serving any purpose. So that is the reason we should have at least have some idea about the client, uh, uh, you know intellectual and cognitive ability in general. And we also can see like from where the reference is coming from. If it is a mental health professional, there is no doubt we can just proceed with it. Otherwise, we might have to, do a basic screening to rule out whether the clients are, meeting this criteria. Also, apart from this, what are the other things where people cannot be included in telemental health services, which is crisis management, suicidal risk, or self-harm behaviors. Those who have this kind of, behaviors, they'll not be involved in the telemental health services. Right? So if at all they have um, a severe psychopathology, again they'll not be able to, access this tele mental health services. Right? Anybody have any idea like who else cannot be, take part in this tele mental health services? Because we have discussed like who can receive the services and then who cannot. In who cannot, we already discussed that who's in suicidal or self-harm behavior uh, clients, and then those who have active psychopathology, right? What else cannot be covered in mental health services? Can you just share your opinion and your suggestions? Okay. So another set of issues which we cannot do a tele-mental health services is family and couple therapy. That is also something which we cannot offer a tele mental health services. Okay. So these are the basic thing where we cannot do a counseling, where we will insist the client or family to come for the in-person treatment. Okay. So keep that in mind. Whenever you encounter such a clients, you please advise them to come for the tele-mental health in-person service. So this is the crucial part of our today's presentation. So you should understand each of the component of this, you know, this ethical and legal facts. So it is little different when it comes to more or less it's similar, but there are some component about the informed consent and then confidentiality and documentation where it will be little different from the in-person services. So let us just start from the client suitability. So first we need to assess the client suitability whenever we just uh, uh, do a intake for the uh, tele-mental health services. So the client suitability, we have to follow certain procedures, right? So first we'll do the intake session where we'll do a brief interview and then try to collect all their details, including the basic socio-demographic details, and then do the basic evaluation. Based on that, we will decide whether the patient will be suitable for tele-mental health services, right? So basically, after seeing the complaints and then uh, based on the evaluation which we made, a brief evaluation, whether is there any risk for self-harm or risk for suicidality, and then potentially the patient problem is having any potential family dispute or family conflicts, we may tend to refer them for the in-person services. If at all it is just uh, based on their current distress, nothing to do with the self-harm behavior and all, then we can just go for the next level of evaluation. So once we decided whether the patient is suitable for the tele mental health services, we should also share the information about what are the modality of tele mental health services is available. And then it is up to the patient that they can select which mode would be convenient for them. For example, we have a, as I mentioned, like the telephonic counseling or mental health services. It will be a mail, text format, or it could be a video call, option. So we have to give the variety of option to the client. It is the patient or client rights to choose which one would be convenient for them. So once that done, we have to get the informed consent. This is a crucial, again, it's crucial part of the telemental health services. Here we need to mention all the details, the basic information, the fees aspect, and then the confidentiality and limited confidentiality, all those detail, including the documentation, um, uh, all this detail we need to include in the informed consent form. An informed consent form always to be in a printed form, like where a patient can e-sign and then send it to you. Okay, so we need to keep that informed consent form, all this detail. If it is a minor claim, we need to get the assent form from the guardian. So similarly, all this detail will be mentioned there. And then once we receive the consent form signed from the uh, uh, guardian, we can proceed, initiate the tele-mental health services. Right. So once you started the assessment, once you started the initiation of tele-mental health services, in every session, you need to assess the possibility of any risk involvement. Okay. So each and every session in online, you need to do one brief assessment, either in the end or in the beginning, whether any sort of risk involvement is there in the session. If you found any risk involvement, you need to immediately terminate the session, and then you need to recommend the person to go for the in-person, mental health services. So this is all about the client suitability. So this is how you need to evaluate. First, you do the intake session and do the brief evaluation about all this thing which we discussed, primarily about the self-harm or any suicidality. Once we decide that, we'll take a call whether the patient will be suitable for in-person or telecounseling. Once the decision has been made, if at all we proceeding with the tele-mental health services, next moment we need to give the option for the client to choose which mode of tele-counseling that they or tele-mental health service that they want. Either it's in a video or in phone call or in a mail format, whatever they prefer, we need to give. And then we need to get the consent form, and it is important for us to mention all the detail in the consent form in a written format. So once we receive the signed consent form, we have to initiate this session, and it's our responsibility to assess each and every session whether there any risk involved in this uh, patient, either in the current or in the nearer future. We need to immediately re-guide them to in-person treatment, and immediately need to terminate the session. So this is about the client suitability, right? Any doubts there? Any clarifications there? Fine. So next comes informed consent. As we discussed, we need to mention all this detail about the uh, just a basic information about the therapy, tele-mental health services, and then what they will be gain out of this, and then what are their responsibility, what's the therapist responsibility, what is the confidentiality thing, what is the limited confidentiality thing, and what is the fee structure, the mode of fees. All those things will be mentioned in the uh, consent form, including the document things, where if the patient uh, uh, progress, and then what are the approaches that we are doing, all those things will be documented. So I'll discuss that in the document part detail. So all these things we need to mention in the informed consent form, and we need to get signed from the patient before initiating any sort of services. So this is about the consent form. Now, conducting the tele-mental health sessions. So it is a pre-booked session. So you need to understand, like when it comes to tele-mental health services, once you assess the suitability, and then inform consent form is signed, then we have to initiate the session. So how we have to initiate? It is pre-booked. So we need to pre-book the session, which date and time the client want the session with us, and all this information has to be either mailed or messaged to the patient, right? And so once the session is fixed, and then we have to initiate the session. There are certain things that we have to keep in mind when we are doing online session. If it is a tele or video conferencing, we have to, make make the patient to understand the environment which they are uh, doing or involving in the session. That should be a distraction free environment, and we have to recommend them to, keep mute all the application notification, all those things, so that we can potentially avoid the distraction during the session, right? And we have to, motivate them to be uh, in a good environment where there won't be any external noise or environmental disturbance. Okay, so this is about the conducting a tele mental health session. Next comes uh, Next comes the confidentiality. So many of us will have a doubt in this aspect because if it is an in-person therapy session, confidentiality is nothing but we might explain to the patient that whatever you share, the information which I will not be disclosed to anybody apart from my supervisor for the discussion purpose. So it will be very very transparent that we communicate to the clients. But when it comes to online or tele-mental health services, this confidentiality is very, very crucial, maintaining this confidentiality because everything that we do, it is in online, it's in open source, right? So, in that sense, there are certain, points that we need to mention with the client regarding the data sharing, data security, right? And uh, and limited confidentiality in this online part as well. So data sharing is like we as the mental health professionals should not record any, like it's a mutual agreement between the client and then the therapist who's involved in telemental health services. So we have to disable the option of recording, right? We should not record any uh, therapy or counseling session which is happening in online mode. So we can inform the client also about that the option of recording is disabled, so there won't be any possibility of you know your information uh, will be leaked to other or it will be shared to other, so that should be uh, established very well. And then the data security, as we know that uh, since it's an online, any hackers or anything that can be happening, right? So if that kind of scenario is happening, neither therapist nor the patient is responsible for this kind of issues. That has to be discussed and then that has also mentioned, should be mentioned in the consent form, right? And we can explain or we can motivate the patient to keep all the protective measures of like securing their password and then keeping the Wi-Fi protected password. All those things we can just re-educate to the patient to keep them in a very very safe. Right? Similarly, the limited confidentiality where if involvement of self-harm or armed threat to the others, where we might have to breach the uh, confidentiality, where we may have to conduct the uh, uh, some immediate services like involving the police or involving any NGOs or organization who's like providing some sort of support to them, right? So that's the limited confidentiality aspect, which will be the common for both uh, tele and then in-person services. Next comes the therapist online presence. So what they meant in this, we have to be very very careful about the social media account which we are handling, like our own social media accounts, right? What content that we are posting, what kind of message that we are posting, because it's very much available in an open forum where your clients also can get access to it, right? So if at all that is happening, it can potentially harm the therapeutic alliance that you are forming with the clients, right? So you have to be very very careful about what the how you're maintaining or handling your social media, right? And the last point, we should not be involved any AI based interventions, artificial based intervention, unless if it is recommended by any policies or guidelines. And also uh, we should not involve patient into any sort of support groups without their consent, right? So these are the confidentiality aspect that we have to make sure we deliver to the patient very, very clearly, right? So next comes the documentation. So the documentation, though it is a online or tele-mental health services, it is very much recommended to keep the uh, recorded forms, the pre-fixed forms of therapy records, right? So there is a reference. Mental Health Care Act 2017 has given a appendix format of what kind of information that we have to, keep track when we do therapy with the client or any mental health services that we are providing. So we have to keep that format, which will basically include all the basic socio-demographic data, right, about the client, age and contact number, all those things, along with the diagnosis which is made previously, and then what are the common goal which is decided in the session, what we discussed, and then what was the outcome, and then plan for the next session, right? So these are the basic information about the documentation of a session that will be uh, keep in a written format and then kept it very, very safely. Okay. Whether the client access to the medical record? Yes, of course. If they're having uh, uh, a relevant rationale for accessing this medical record, which we can provide. See, if you work in a private sector, if you work in you are doing a private practice, it is completely different. When it comes to working in certain established organization, for example, some organization like Nimans or Ramachandra, all those things, where all these things has to already, in a format where you just need to follow the format and then kept it. Documentation, everything will be, kept it. When it comes to access to the medical record, it is uh, it is the responsibility of a management, where the client will approach the management, primarily the superintendent of medical superintendent, where they have to give a written format of letter, request letter, where the superintendent will inquire about the need for the medical record. If it is accepted, they'll issue it. So we don't have any role in this, you know, uh, process. If at all you are working in the private sector and who's doing independent practice, we have to keep all this in mind, where all uh, uh, the ethical and legal components we have to maintain, and then if at all a person is need of these documents, we have to do a primary evaluation and then decide whether it can be provided or not, on what purpose they are asking, on what uh, basis for this medical record that they are asking. Based on that, we can decide whether we will be giving or not giving, right? So this is about the ethical and legal part. If any of you have any doubts in this aspect, we can discuss here, because it is very, very crucial and important aspect of tele mental health counseling. So if you have any doubts, clarification, please ask. Okay. So if not, then let us proceed for the next slide. So now we are going to just see what are the government uh, airplane services that is available in the field. So now you can see that there are different, organization, as I previously also discussed about that Sanjeevani Society, Sneha, right? So along with that, there is something called Telemanas, which is an initiation by the national government, and there is another service called iCall, and this two I've already discussed, right? So apart from that, there are a lot of other helpline numbers which is uh, available in government websites. So there is a specific website and helpline for the women when they have distress. So there is a helpline number called 1091 for women distress, 103 for women's violence against women's violence. So there are different kind of helpline numbers. Okay, who's also providing some sort of uh, emotional support. Uh, so there is a big difference between the uh, tele mental health services versus the government helpline, which we see right now. So the government helpline is primarily giving the telephonic counseling or telephonic services, whereas the tele mental health services involve like all these three partners, right? So how the tele counseling thing is happening? Like right now, I am working in one association where uh, there are certain procedure that we follow in that services. So based on the understanding, there are some basic skills that is required, which is nothing everybody might be aware of it, like effective communication, and we have to have the hands-on experience in distress or crisis management, and then we do have a cultural sensitivity about callers' background, so that we can provide the better service to them. So now you can see the contradiction between the crisis management, right? Because in tele-mental health service guidelines, where those who are like um, doing a private practice or working in a organization where when it comes to crisis management, they definitely recommend the person to come for the in-person treatment or in-person evaluation. Whereas this sort of a government or NGO based telecounseling, their primary focus is handling the crisis management. Like when they are patient have a suicidal ideation or suicidal threat, the caller's responsibility is to manage the call and then reduce the uh, you know the vulnerability of suicidal ideation. Okay, so this is what the basic difference between the uh, telephonic counseling versus tele-mental health services uh, in general. Right? So how our system functions. So what is our tele counselor's role? How we do plan the tele counseling? So initially, when the caller call for the given number, it'll you know go to the IVR system. Based on that IVR system, which therapist is available, the call will be transferred to them. Once the caller is once the therapist pick the call, they'll interact with the patient for 15 to 30 minutes, and then in that session they'll identify what are the immediate concern and provide guidance for them. Okay. And meanwhile, also they will do a brief assessment and then try to understand if it is any sort of uh, uh, a serious or severe mental health issue. They do have a referral system where they would refer to the higher authorities or DMHPs, and they would also refer to the district mental health departments. Right? This is how the telephonic counseling takes places in our tele mental health services. So we as a counseling services faces different challenges. I just named them a few here. So the basic and primary challenges is the technical barrier where the poor internet connectivity, right? And then it is also very difficult to keep client engagement because we can't see on what and how they are like interacting with us. So maintaining their attention and participation is very difficult. Okay. And we do also looking for the training and capacity building because it's very essential to handle the crisis and then the complex issue that is coming in the way, right? So these are the challenges that we faces during our services. So based on this whole content, uh, what we uh, need to understand, though there is a growth, there is a change in the uh, mental health, services, but in person is still like play a vital role because it can pick and then rule out a lot of other challenges which we may not be able to pick over the online counseling, right? So, for example, crisis or the severe psychopathology or any other difficulty, which will probably we might be miss out in the mental health services, right? So, papers also the findings also suggest that you know um, telemental health services is having a very eff- effective intervention approaches, and it has given positive outcome to certain disorders, certain mental issues. But still, we have to understand that just a few years of online counseling, so we lack a lot of databases, so we can't compare this with the in-person field. But still, the telemental health services is like growing very rapidly, and then because it is becoming and gaining lot of other potential assets. So uh, uh, this we can see that after the COVID, the telemental health services spikes, in I. So with this, I end my presentation. I would like to take any question or any suggestions or feedback if you have.
Hi, sir. This is Disha. Can you hear me?
Yes, yes.
Okay, I have a doubt.
Yeah.
Can a fresher join in telemental health as a, and can they choose it as a, career option for the freshers? It's my doubt. Is it really helpful because there is a gap between practice and studying after PG? So,
Mhm.
will that gap be bridged by any supervisor? Will be there for help us. So that's my doubt.
Yes, yes. Thank you, Nisha. Very insightful. So, of course, if you ask me like whether we can start career right after our education in a mental health services, I would, I would strongly suggest and recommend you to, take up this. As you rightly mentioned, uh, and other guidelines also mentioning that after your PG, you're allowed to practice and then allowed to do any sort of therapy, either in person or online session. But it is our own, responsibility to see like how competent that we are to handle such issues, right? So for that, you rightly mentioned like taking appropriate supervision would be really helpful in terms of coming out and then sorting if any problem that you are facing during the counseling services. As IMAPs, we do offer a supervision services too. So if at all you have any queries and then any doubts or regarding the tele-mental health or in-person services, mental health services, you can reach out to us. There is a provision for supervision in IMANS.
Okay, thank you so much, sir. It was a
Thank
nice presentation.
thank you. Thank you. Any other confusions or
So there's a question in the chat box.
okay.
So they've asked if children can be provided telecounseling.
Okay. Okay. Yeah. Just let me stop the presentation. So, yes. Yeah. So the okay. Children can be provided telecounseling. As I mentioned, uh, yes, they can provided uh, telecounseling services, but keep that in mind. We need to take a uh, consent and then inform assent form from the guardian. When I say that guardian, we also need to involve the guardians to understand the problem, because if a child with any severe mental health issue, because that's the reason I was like uh, strongly suggesting you all to read about the Mental Health Care Act and then the POCSO Act and then the RPWT Act, all those things, because it is clearly distinct that to whom we can work and then to whom we can't work. Okay. So if children with special need, children with some form of disability or any other mental diagnosed condition, of course we have to be think twice before taking the case, because unless until have a proper license per se, we may not be involved doing therapy or involving them in any sort of counseling, right? Other than this sort of mental health issues, if any psychological problem, if child has, definitely we can, do the telecounseling or tele mental health services. Okay. Any other questions? I was expecting somebody or someone will definitely ask about the crisis management, because I said it's different thing between the tele-mental health services versus government telephonic services, right? So when we do a tele mental health services, if we get patients with or clients with any self-harm behavior or any self-harm ideas, definitely we should ask them to go to the uh, uh, mental health in-person mental health services. But when it comes to tele-counseling, telephonic counseling, currently which we are offering in Telemonas or Sneha, all those tele-based counseling, crisis management is a part of our work, the daily routine work which we get, because the people, those who are seeking for this kind of help is very, uh, very uh, underprivileged people, those who are calling from very rural or areas, who will not be able to access the in-person treatment. So they might have a lot of limitation in terms of travel, in terms of money, all those things. So for them, it will be difficult for us also ask them to go for the in-person treatment. So what we primarily do is the crisis management. So in that crisis management, there's a specific component of 5 component psychological first aid. Okay, so it is very interesting. You try to understand this. So what is this 5 component psychological first aid? So we first, when we receive the call, we have to make the patient to understand uh, the psychological connect which we show towards the client. For example, if receive the call, we need to make sure whether the person, those who are speaking in opposite line, need to understand um, our readiness for services. So by anything like uh, we can use different strategy of inviting client to talk more, listen very empathetically, show, and then try to fix their facts and feelings, try to connect with their feelings, and then summarize all the issue that they discuss with us. So doing all this, what we are uh, what we are trying to connect with the patient is that we are here to listen you and we are here to understand. Okay, so once this first step is established, we need to go for the second step, exploring the dimension of a problem. Like they just come for the fixed mental set of a crisis situation. So our job is to inquire about the immediate, past, and present problems associated with the current stress, and then we also need to evaluate the lethality component, like the risk for any harm involved. Okay. Third step is examining the possible solutions. So once we receive the uh, intervene and inquire about the past and present and future problems, we need to examine the possible solutions. So what are the possible solutions that the patient is already tried and then plan to try? So by exploring this, we can you know guide or suggest some of the new uh, techniques or new suggestions to their problems. Okay, and then fourth comes making a concrete plan. So that is in two-way process. First level is when there is a risk is low and the patient can function by themselves, we take a facilitator role. Okay. The opposite of it, when the lethality is high, when the risk is high, and then the patient is not able to do anything by themselves, we take a directive role. Okay, facilitator role. What we do, we talk, you do. So basically, you talk, we talk, you do means we will discuss, and you try take all the measures that I'm suggesting. For example, I during this conversation, what we supposed to offer is we have to explain the patient about like what are the services that is available, what are the immediate intervention that they can do for their this kind of self-harm thoughts, what are the immediate resources that they can reach out, nearby helpline or nearby NGOs or emergency services which is available in their locality, involving police, involving any volunteer services, all those things. What we can do as a facilitator, we discuss and then guide the patient to do by themselves. This is when the risk is very low and then the patient can do things by themselves. The opposite of it, when the risk is high, where we take a directive role, we talk, but I will act. What I'll do, I'll just simultaneously connect to all the resources which I mentioned right now. So as we as a telemanus employees, what we do while engaging with the conversation with the patient in call, Simultaneously, we connect to the PDOs, the police department, try to locate the patient. Simultaneously, we pass the contact to the DMHP, the district mental health people, ask them to reach out to the patient place, right? And then simultaneously, we work on getting their relatives or family members number and try to connect simultaneously. All those things, as a counselor, we do. So this is when the patient is having high lethal and then low in acting out of all this. Okay, so this is about the fourth step. The fifth step is, once we save the patient in this situation, we have to make a follow-up calls for 5 times, right? So we need to call 5 different times to check whether the patient is maintaining well. What are the steps that we suggested? How many of them is currently carried out, and how they are right now is feeling. So this will be monitor for another 5 sessions, like 5 weeks. We repeatedly call the patient and then try to engage with them in terms of finding out what are the challenges that they are facing and then how they are trying to come out of it. So this is about the basic 5 component of psychological first aid, which we have to do when the client is in crisis, right? So this has been given by Carl A. and Salik. Okay, this is the author name that you can just go and refer. Okay. Also, another important thing is when you uh, uh, working with patient with crisis or the patient with any suicidal ideation or self-harm behavior, one important thing that you need to understand the intensity of a suicide behavior. Because when it comes to suicide, there are different terminologies that we need to aware of, right? So suicide attempt, abrupt suicide attempt, suicidal ideation, death wishes, suicidal intention, lethality, and deliberate self-harm. All this term is denote different meanings, right? So you need to understand and identify in which sort of uh, uh, this risk is there with the patient, right? Unless until if we understand this background of the suicidality, we will not be able to provide the right service to the people those who are in need, right? So you need to understand what sort of help that they are looking for. Based on that only we can guide for the appropriate services, because as we seen in that psychological first aid, we need to understand whether they have a high lethal, low lethal, then only we can take a facilitator role or directive role, right? So to understand that, we need to understand all this terminology, and then we need to understand and assess what exactly the patient is right now going through. So once we understand that, we can just proceed for the right management for the people those who are in need. Okay, I hope it is clear. Again, if you have any doubts, please feel free to ask. Yeah, there is one question in uh, chat box. The challenges, real-time challenges that you faced in tele-mental health provider. Okay, so this one of the challenges in helplines, like especially government helpline, because it is different. As I mentioned, it is lot of difference between the tele counseling as a private practitioner, which we do. When it comes to telephonic counseling by the government services, where the number is freely available to everybody, there is one challenges which we face is handling the prank calls. You encounter a lot of prank call when we do telephonic services when it comes to government services, because many people just call and then do a lot of prank. So it's very difficult to handle them. And sometimes patient with psychotic severe psychopathology, where they will not even listen what we speak. They just call, they just speak whatever they just have, and then they cut the call. Okay, so these are the challenges which we face as a tele counselor. Uh, yeah, these are the real time difficulty which we do. Any other doubts, clarifications?
Is there any other question?
Any other doubts, clarifications? If you don't want to ask in the voice option, you can also type in the chat box. Do we miss any question in the chat box? No, right?
And no, sir, we've covered everything that has been asked so far. So if there's any other question or feedback you want to give, you can use your chat box too.
Yeah, yeah. The dropouts are quite high in or tele mental health services in general. The reason could be, again, it could be many uh, things, because as we seen the limitation, there are a lot of limitations, isn't it? So so probably I never come across any specific reason suggested by any uh, uh, papers or datas. So my understanding would be like uh, tele counseling, keeping them engaged in tele counseling is really challenging. For example, a particular conditions like anxiety or phobia or any other sort of complaints, where a lot of relaxation techniques or uh, uh, the activities, the thought diary or emotional record, all those things involved. Monitoring them and then guiding them in in-person therapy would be very effective. But doing that in online session would be challenging. Probably that could be the one of the reason. I'm just giving one bit of information. Similarly, we can understand the limitations which is there in online session, because of which the dropouts might be high in number. Anything else? Anything else? Providing the telecounseling for the client to pay. No, no. See, the telecounseling thing is work differently. For example, now if you need to, as I mentioned in the initial session, where I said it's pre-booking. What I meant by pre-booked is, if a client is looking for a therapy tomorrow, they need to book the session by paying fee by today itself. So there's no involvement after session is over or while the session is conducting. So the fees aspect should be pre-disclosed and then pre-booked. So keep that in mind, because it is answer to the previous question also. When we have the system of taking fees in a later, the dropout rates also might be increased because they will not pay and then they'll leave, right? So you need to take a pre-booking. So that is the advisable, method of doing online session. Pre-book the session, get the fee, and then do the session. That's how you need to, start your practice. Thank you, Veena. Any other questions or doubts?
Okay. Is there any other question? Okay.
If not, we can wind up the session, right?
Yes, sir. Thank you so much, sir, for the session.
Thank you. Thank you all for patience listening. I hope it has served some purpose. Yeah. Thank you all.
Thank you, sir. Participants, before you leave, um, I'd just like to take a brief moment of yours to introduce you all to an upcoming program of IMAPS, which is the intensive professional training in CBT, about which I mentioned earlier during the start of the session. Uh, so the main aim of this training is just so that we can help you understand the theoretical foundations of CBT and help you gain practical experience, that is actual quality experience in applying CBT techniques in a clinical setting. So this is a 12-week course for which we are limiting the participant intake to 10 to 12, because we want to focus more on giving a personalized learning experience, and we also are providing free case supervisions, for which we need a smaller class size. So we'll be taking in at the maximum 12, that is 10 to 12 participants only. So, as I mentioned, this is a 12-week course where you'll have 8 weeks of lecture, and you'll have 2 weeks of role play, 1 week assignment, and 1 week case discussion. And students having a bachelor's degree in the stream of psychology, social work, school psychology, or psychiatry, uh, and a master's degree too in behavioral sciences will be eligible for this course. So the preference will be given for professionals who are practicing and then to the PG students who would be interested to enroll for the same. So this is a syllabus that we'll be covering during the course of 12 weeks. We'll start with the history, and then we'll get into the theoretical aspects. Of course, we'll teach you about the skills of a CBT practitioner. And here you can see we have concentrated on the techniques of CBT to elicit automatic negative thoughts and to modify the same. And we will be orienting you, and we'll be covering in depth the techniques and how you can apply them to various scenarios: Socratic questioning, vertical descent, cognitive restructuring. And we'll also be discussing about session structuring and case conceptualization. So when it comes to the technique, I think when it comes to reading about a technique and practicing it, you'd see they're miles apart. So to bridge the gap, we have role play, where you will be supervised by our expert who will be there to deliver your session. Under their supervision only, you will be performing role play on the techniques that we'll be dealing with in the sessions, which include Socratic questioning, vertical descent, cognitive restructuring, and we'll also be looking at how you're structuring the session. So, as I mentioned earlier, in addition to this, you will also have supervision. So the main aim of this is, at the end of the course, we want to see 10 to 12 professionals who come out of our program as professional CBT practitioners. So that's one main reason we insist on having a smaller class size. You'll have personalized interaction with mental health professionals who practice CBT on a daily basis, and you'll also receive personalized guidance for the same. So, should you be interested in availing this course, please do get in touch with us through WhatsApp or through our Instagram or through our mail ID. Once again, thank you so much for having attended today's session, and we look forward to seeing you in our other programs too. We have two other workshops coming up in this series, one on art therapy and one on essential skills for a psychologist. We look forward to seeing you there as well. Once again, thank you so much.